Amniotic fluid embolism is a rare disorder. So the mechanism is uh, amniotic fluid is a thromboplastin-rich fluid, and this fluid either through rents in the membranes or through the placental side will enter the maternal circulation. Now it is rich in thromboplastin, and it will go and lodge in the pulmonary artery, and it will block it and lead to it will initiate disseminated intravascular coagulation. So why is this happening? So as soon as this happens, there is massive deposition of fibrin, platelets, etc. come and they form a clot in the pulmonary tree. So this is seen in two stages. First stage, there is just cardiorespiratory embarrassment, which is stimulating thromboembolic phenomenon, and because of this, there will be later on there is. So first stage is just cardiorespiratory arrest. Second stage presents with DIC. So what happens wherever the clots are formed? These clots, the fibrin lytic pathway gets activated. It will lyse the fibrin, and now there is uncontrollable bleeding. So this uncontrollable bleeding is because of will lead to profuse bleeding per vaginum or through venipuncture sites and all. So it is divided. Clinical manifestations are seen in two cases, and the patient profile is usually somebody who is just delivered or delivered within 30 minutes and is suddenly going into an unexplained shock. So we have two sets of clinical features. One is before delivery and after delivery. Before delivery, there will be bruising and bleeding through venipuncture sites, through gastrointestinal sites, or hypotension. And after delivery, it is again the same thing. We say that there are two stages. First, cardiorespiratory collapse, and second stage is DIC, where there is bleeding from different orifices. There is also postpartum hemorrhage. And when we check the feel of the uterus, normally postpartum hemorrhage is because of atonicity, but here the feel of the uterus is firm, it is good, hard, well contracted uterus. So the next thing that comes to our mind is traumatic PPH. So we rule out causes of trauma, and there we see that there is PPH. And hemorrhage is occurring usually after 1 to 2 hours after delivery. Bleeding can be there from episiotomy wound, hematomas, vulval hematomas, etc. can be formed. So in investigation, what do we check? We go for peripheral smear. In peripheral smear, we see that there is um, thrombocytopenia. Then we go and check for fibrinogen level, fibrinogen level, activated partial thromboplastin time, prothrombin time, and then fibrin degradation products and D-dimer. So this D-dimer is a very specific test because it will tell us about the clotting. Then we can do one more bedside test called the clot observation test or venous test. In this, we draw around 5 ml of blood from any of the veins. We keep it in the test tube at 37 degrees Celsius. That is at room temperature. You keep it within 6 to 10 minutes, a clot will be formed. So based on the time in which clot is formed, it will give us a rough idea about the fibrinogen level. So if clot is formed in less than 6 minutes, that means fibrinogen level is more than 150. If it takes more than 30 minutes for a clot to form, then the level is less than 100. And so now coming to treatment, first is preventive. All the underlying risk factors have to be prevented. Then management. In management, we have to replace the lost volume. So here basically there is bleeding, so we'll have to correct that. We can do it by different sets of things. We can go for whole blood transfusion, or we can go for fresh frozen plasma. So in fresh frozen plasma, it is acting by increasing both the volume of blood, it is replacing volume, as well as clotting factors, because it's rich in fibrinogen, clotting factor 5, 11, 12, etc. So this is used when we want both volume plus coagulation factor. Cryoprecipitate is only rich in coagulation factor, so whenever any in factor 8, fibrinogen, von Willebrand factor 13. So whenever any of these factors is missing, then we give cryoprecipitate. Then next, coming to platelet concentrate. When patient has low platelet count, that time we prefer platelet concentrates. They have to be ABO and RH specific, and you should transfuse that. Then packed cell volume, when you want to improve the oxygen carrying capacity of the patient, of the blood basically. So we can use something called auto transfusion, wherein during operation, whatever blood of the patient we had received, we purify that. We just filter out all the blood cells and we can give it to the patient. And this is done through a machine. That machine is called as a cell saver. Then we can go for artificial hemoglobin derivatives also. Then ideally we give anti-clotting agents like heparin. and we can also add other like fibrinolytic agents like fibrinolytic inhibitors like EACA, then apropitin. Such agents can be added.